It's really an honor to be here today. And some of you might remember that I was here actually just before the pandemic in giving a grand rounds in December of 2019. And in terms of preparing for today's talk, I looked at my talk back then, and I really focused that talk on the changes that were happening with the board related to continuing certification and the CertLink program. And really today I'm really going to be focusing, as you'll see, in terms of describing the new changes and developments at the board related to the initial certification process. I have a few disclosures. One is that I'm a full-time employee of the American Board of Otolaryngology Head and Neck Surgery. The other is that I'm a diplomate. I'm a board-certified otolaryngologist head and neck surgeon, and I also participate in our continuing certification program, as all the directors do. I always like starting off talks by reminding everybody about the mission of the board. The American Board of Otolaryngology Head and Neck Surgery is not a membership organization. It's a certifying body. And as a certifying body, we do not have members. We do have diplomates, as you can see on the screen over here, described in the mission statement. Diplomates are board-certified otolaryngologist head and neck surgeons. Our primary stakeholder is the public. It's not our members, because we don't have members. It's the public. And the boards started back in 1916 with the American Board of Ophthalmology, related to the development of the concept in the United States of professional self-regulation. So regulation by specialists for the specialty and for the public, rather than the government doing it for us, like medical licensure. We define the standards of training, knowledge, and professionalism related to initial and continuing certification. Now, if we look at the mission statement of the board back in 1924, the original mission statement, it was very similar to the current mission statement. There are two big changes, though. One is that we're not the American Board of Otolaryngology, we're the American Board of Otolaryngology Head and Neck Surgery. Back in 2018, we were successful after 35-year effort to get head and neck surgery added to the name of the specialty. So if you ever hear me correcting people to say it's not AB Oto, it's AB Oto H&S, it's something that we take a lot of pride in, that it took a huge effort over a long time by many leaders in our specialty to get our board national, the name of our board changed at a national level with the American Board of Medical Specialties. The second thing is that with the original mission statement, just initial certification was described. There was nothing about continuing certification. We've had continuing certification as a requirement for all newly certified individuals in 2002 and afterwards. As you could imagine, back in 1924, when you got certified, it was certification for life, simply because advances and changes in medical practice really didn't happen. But now they happen really rapidly. Even if you do not keep up over a 2 or 3 year period of time, you're behind. And so it's really important that that we check in on our board-certified otolaryngologist head and neck surgeons every so often with the continuing certification program, to make sure they're keeping up with standards, keeping up their knowledge base, and keeping up with all the new developments in the specialty. As a certifying body, the certifications that we provide, the first is in the primary specialty, otolaryngology head and neck surgery. And more recently, we have something called a focused practice designation it's a long word here, adult complex thyroid parathyroid surgery. And we're the co-administrative board with the American Board of Surgery with that focused practice designation. This is a new development. The first exam for this was earlier this year. I already say last year, thinking it's 2026. It was in April of 2025. I'm not going to have time to talk about the focused practice designations, or quote-unquote FPDs, but if anybody is interested in learning more details, they could go to our website or certainly talk with me afterwards. In terms of subspecialty certifications, we offer 3, complex pediatric otolaryngology, neurotology, and we're one of the 6 co-sponsoring boards for the sleep medicine sub-certification. In our specialty, there's many more subspecialties, period, but we have 3 subspecialty certifications simply because based on the standards at ABMS, we're only able to develop and provide sub-certification in areas that have fellowships that are ACGME accredited. And these are the 3 ACGME accredited fellowships in our specialty. In terms of the assessments that we deliver as part of the processes of these certifications, for the primary specialty, there's the otolaryngology training exam, or what a lot of people call the in-service, the written exam for certification, the oral exam for certification, and then for the focused practice designation that I just mentioned, there is a written exam as part of that process. In terms of the subspecialty certification, there's a written exam for the complex pediatric otolaryngology, and in the past there was an oral exam for neurotology. That is moving to a written exam starting in 2028, and that is another new development that I won't really have much time to talk about today. But if anybody in the room is interested in that further, they could go to the news and announcements on our website, or certainly talk with me afterwards. But we're moving to a written exam as the next time we administer the neurotology exam, which will be in 2028. And then for the continuing certification, we used to have a point-in-time, quote-unquote, MOC, or maintenance of certification exam. We stopped administering those point-in-time exams in 2021. Now we're fully integrated with the CertLink longitudinal assessment program, and that's what we deliver for the continuing certification now. Now, all our certification programs, the oversight of those programs, along with the strategic direction and strategic initiatives of the board, is from the board of directors. As you can see on the screen, this is a photo of our board a few months ago. I'm sure many of you in the room recognize a lot of people on this screen. This is I'll tell you, our board is an incredibly devoted and dedicated, committed group to the certification process. And really you couldn't find, I think you couldn't find anybody else more committed to the mission of the board on this screen. And they put in a tremendous amount of voluntary time and effort towards the mission of the board. Now, the board, I mentioned volunteer effort, and these are other volunteers for the board, and we could not succeed on our mission without this incredible volunteerism that we have. And many of you in the room have been volunteers for the board, and for those of you who have been, thank you so much for all your help and assistance over the years. We have on our item writers, those are the individuals who create the questions for the multiple choice question test. We have 95 item writers now who write 12 items a year, and that's our task force for new materials. Each year we have a different number of oral examiners based on the number of candidates we have. This past year we had, with exam coaches, 114 oral examiners. And then we do have, so the item writers and the examiners are appointed to those positions by a committee at the board. But we do have elections at the board. The way you become a director on the board is by being elected to being a director. The way that you become an exam council member, or what we used to call a senior examiner, is by being elected. There's an election at the board that those are elected positions. And the exam council members are what used to be called senior examiners, and those are individuals who do more leadership, have more leadership roles and responsibilities amongst the organization, and also roles now related to constructing the exams themselves. I can't proceed without mentioning the incredible, devoted, and dedicated 13 full-time board staff that we have, and 4 part-time staff. Our central office is located in Houston, Texas. We're not in Alexandria, Virginia. We're not in Washington, D.C. We're not in Chicago. We're in Houston, Texas. And really, we have an absolutely amazing staff that implement the policies of the board. So who is the board not? Who are we not? as I mentioned, the board is a certifying organization. It's not a membership society. The Academy, on the other hand, is the largest membership or professional society for otolaryngologists probably in the world. And the focus of professional societies typically is not on the public. It's based on advocacy for the physicians and health policy, education, and research. So the board is also not an accreditation organization. So the accreditation organization for residencies is the ACGME. It was the board actually until 1953, and then we handed that over to the ACGME. And at the ACGME, there's the review committee for otolaryngology head and neck surgery. They're responsible for accreditation of residency and some of the fellowships in our specialty. There are 10 members of the review committee. 3 of those individuals are nominated to serving on the ACGME review committee by the board, and the executive director of the board serves ex officio on the RC. So with that as an introduction to the board, there are 3 topics I'd like to cover today. Definitely the first 2 about the written exam changes and the oral exam changes that are going to be really important, particularly to the, all the residents in hearing this talk today. And, but I'd like to also cover this topic of forensic psychometric analysis that for those of you who have attended the SUO 80 Opto meeting over the last 2 years, you've probably seen some of these data, but I know a lot of you in the room have not attended that meeting. And so I think it's important to try to cover that also if we can. So a few updates about the written exam. As you hopefully know by now, the written exam moved to a July administration date starting this year in 2025. And if you look at the board's website at future exam dates, you'll see that we already posted our written exam dates for 26 and 27, and those are also July dates. I can tell you it's been a 7 to 8 year effort to get our board to a July administration. And that's simply because it's a very popular month for certifying organizations to be administering their exams. The Pearson VUE centers that we contract and work with have very busy Julys. And that's not only amongst medicine, but that's amongst like beauticians and lifeguards and all these other folks that do certifying exams at Pearson VUE centers. So we finally got into a July administration, and I do not foresee that changing in the near future, assuming that Pearson VUE continues to give us a July administration date. And as I mentioned, we're good through at least 2027. The way that this affects potentially the department is really when fellowship programs start as their start date. And I could tell you that there are some other specialties like orthopedics that have had a July administration date for really, really long time. And the fellowships on their own decided to have a national August 1st start date to just give all the graduating residents time to take their boards and have a transition month to fellowship. But that's certainly not a decision or recommendation from the board. I'm just mentioning what another specialty has how they've managed that. The pass rate for the last 2 years has been 87%. And so a question I got this year when I reported it was 87% is, was it related to moving the exam to July? And well, it wasn't, because it was 87% in 24 when we had the August administration date for the exam. Typically, the pass rate for the written exam has been like 91 to 95%. It's been 87% for the last 2 years. We're not really sure why. There's a lot of speculation that it's related to the changes in training related to COVID, because the first group that had the 87% pass rate was 2024, and that was the first group that went through the entirety of residency training in our specialty during COVID time. But it's really speculation, and we don't know, and it's something that we're going to track and follow. The important thing from the board standpoint is that the standard to get certified remains the same. And so that number might go back to its baseline. It might also go down a little bit. But but it's really important that we maintain the same standard and don't change the standard based on the pass rate. So the next thing I wanted to talk about with the changes to the written exam is the new exam blueprint, which we're really excited about, and I'll describe why. There are many in the room that were queried by the board last year and asked to participate in a very, very lengthy survey, and it was our practice analysis survey. And the reason we did the practice analysis survey was really to evaluate and assess whether the written exam blueprint was appropriate or whether it needed to be adjusted and changed. So conceptually, as a profession as ours or any profession that has a certification process, you need to measure and evaluate what's expected of safe and effective practice. That determines what's on the certification exam. That ultimately determines what is the training and education of those individuals. And to measure what's expected of safe and effective what's expected of safe and effective practice, that's what the whole practice analysis is about. For those of you who completed the survey for the board, thank you so much for doing that. Of the task statements that you evaluated how frequently you do that in your practice and how critical is it that you know how to do that task for safe and effective practice in the specialty. So there were 2 domains for each task statement that you needed to rate. And based on the data, it once again drives what should be on the test, which is the exam blueprint. So basically, the exam blueprint is derived out of the practice analysis. And when I say derived out of the practice analysis, it's not completely. It obviously takes a human and experts to evaluate the results and to think about how that influences and affects change. So it's not the practice analysis findings aren't in all itself going to determine the blueprint as much as help inform the board about the blueprint and about the appropriate nature of it, as you'll see in a minute. So this is on the board's website now, so there's no reason to take photos of the screen or anything like that. At the SUO conference, I saw a bunch of people taking photos, but this is on the website, and you could see over here that the blueprint for the written exam has 2 dimensions. The first dimension is the practice area. And you can see the practice areas across our specialty. And you can see the previous blueprint weights and the new blueprint weights. The new blueprint weights are based on information we obtained from the practice analysis, and once again, informed by subject matter experts evaluating those data from the practice analysis. And you can see that there are some areas that the board felt it was appropriate to increase the content on the written exam, such as pediatric went from 11% to 18%. Rhinology went from 12 to 16%. There were some areas also that the board felt needed less attention in terms of the blueprint. And those being facial plastic surgery went down 5%, otology 4%, and head and neck 3%. And in terms of the impact on the number of actual questions on the exam, you could see that what those percentages equate to on the either more or less questions that candidates should expect to find on our exam. Now, I mentioned the first dimension is the practice area. The second dimension of the blueprint is the patient care process type. The numbers here really did not change based on the practice analysis. The 15% are still clinical fundamentals, 85% are specific to the practice areas themselves. The major change here is that management used to be 3 different categories of management: surgical procedures, surgical concepts, and non-surgical. We combine the surgical procedures and the surgical concepts into one category of surgical of 18% of the exam. The total management of 30% had not changed compared to the prior blueprint. So that's the only change, is that we moved management from 3 categories to 2 categories. Now, the last area here of change is completely new to the blueprint. And that's a third dimension to the blueprint. And that's for each of the practice areas. We got such incredible data from the practice analysis that we were actually able to, within each practice area, distill it down to what percentage from each of those subdomains in those practice areas should be reflected on the exam blueprint. So this is an example for facial plastic surgery. You can see there's 6 subdomains. And for instance, of the 14% of the facial plastic surgery questions, which are 14% of the questions on the exam as a whole, 34% of the facial plastic surgery questions are nasal, 20% are aesthetic, 18% are facial trauma, et cetera. So the board feels that this is going to give the candidates a lot more information to help them prepare for the written exam. In terms of the implementation, for 2026, the in-training exam, so for the residents, the in-training exam that you'll take in a few months is the old blueprint. So if you go to our website and you look at the blueprint for the in-training exam, the old blueprint, you'll see the old documents and the old blueprint there. But for the written exam next year, then we'll be implementing the new exam blueprint. And then for 2027 and moving forward, both the in-training exam and the written exam each year will be the new blueprint. If you want to see the new blueprint, you could log into your physician portal, click inside ABO-HNS. You see practice analysis, you click on that. And there are 3 things you can see over here tiles you can click on. One is a summary of the process if you want to learn more about practice analysis. Another, as you can see at the far right, is the exam blueprint. But then in the middle are the task statements. So for the first time, the board has decided to publish all roughly 750 task statements that were used on the practice analysis to get that data. So as a resident, if you're interested to know, well, what type of things are in nasal facial plastic, you can go to the task statements and you can see the actual task statements that were used to generate those data. You could also click on written exam, and then you'll see a tile over here of exam blueprint that you can click on to get the blueprint information. And once again, that PowerPoint slide showing the actual changes on percentages and the number of questions is there also. So I'd like to transition now to the oral exam, and before the pandemic, the oral exam, which is the final step in the certification process. So getting board certified is a process, and part of that process is successfully completing an ACGME accredited residency program. Part of that process, and the last step of that process, is the oral exam. Before the pandemic, we had an exam that was 5 stations that the candidate went to. 2 were general otolaryngology. 1 was facial plastic surgery. 1 was head and neck surgery. The other was otology. There were 2 examiners at each of those stations. The candidates were examined on a total of 15 cases. So there were 3 cases for each of those 5 stations, 40-minute sessions. Now, at each of the stations, what was being tested was applied knowledge based on authored, structured, standardized cases. So as a candidate, say walking into the head and neck room, you had no idea what those cases were going to be. They were unknowns to you at the time. And you could be asked anything about everything in our specialty during that exam time of 4 hours and 10 minutes. And it was an in-person examination. So once again, it was primarily an exam that was testing applied knowledge. So then when the pandemic occurred, we had to rapidly transition to doing what we did really, really well, but in a virtual environment. And very fortunately, we were successful at doing that from 2021 to 2023. And over the period of those years, we administered 5 virtual oral certifying exams. And here you can see, I think everybody in the room knows somebody in the slide over here. So Chris Hulsinger is in the top middle over there of the Hollywood Squares. And we were 99.9% successful with execution on this exam. And there was one candidate over 5 years, over 5 administrations that could not be examined and needed to move to the next administration. And that was because the candidates prepared exceptionally well, the examiners prepared exceptionally well, and the board staff did probably double the amount of work than in-person regular oral exam. I mean, really, it was that much more work for the board staff to make sure these exams ran without a hitch. So whether we could do it virtually was not a question anymore. Certainly, we showed that we could successfully execute. And from a psychometric standpoint, our psychometrician was very happy with the psychometrics and did not have any concerns about the psychometric validity of the pass-fail decisions that we were making. But prior to the pandemic, the board for several years was already discussing the future of our oral exam and whether the oral exam, even in the current status in person, was really how we wanted to continue on with the exam. And one of the reasons why we had so many discussions about it was that there are a lot of issues that come up with diplomats later in their careers, not related to the lack of knowledge, but related to the lack of professionalism and ethics. And that's something that is really tough to test on a knowledge-based oral exam. And you can't really test it on a multiple-choice question test. And we actually spent a few years contemplating and thinking about how to integrate ethics and professionalism into our exam as we had it pre-pandemic. And those structured protocols never did well psychometrically because everybody knew the right answers, but you didn't know what they'd actually do if they were in that situation. So as we were emerging from the pandemic, we got back to those pre-pandemic discussions and really reflected during this board meeting in March of 2023, reflected on the ultimately what is the purpose of the exam. And the purpose of the oral exam, once again, as I've described, this is the very last step in a long process to get board certified, is to determine whether the candidates to certification have the requisite knowledge, judgment, and skills to assure to the public and the profession that the candidate meets the standards for certification. And the knowledge, once again, we've already tested on the written exam, but the judgment and skills is what we really felt we needed to be able to assess better. And that judgment and skills goes into the professionalism and ethics as part of that. So during that meeting, we had presentations from peer surgical boards, particularly neurological surgery, orthopedic surgery, and plastic surgery. And the board as a whole, we were incredibly impressed by what they were doing, specifically around the assessment of candidates to certification with what they're actually doing in their own practices. And based on those discussions, based on those presentations from those other boards, the board decided to make a transition to an oral exam that incorporates cases from practice into the content, aiming for implementation this year in 25, which we did conduct the exam earlier this year. And we started communications right after this meeting to our community as a whole that we were putting our current oral exam on pause for now until we redesigned and reintroduced it in 2025. Now, as you can see on the screen, I say incorporates cases from practice. Several of the other boards, they have a hybrid exam where they have rooms that are unknowns to the candidates and rooms that are from the cases from their own practice. So the question was whether to move to an exam that was solely cases from practice like orthopedics does, or to move to a hybrid exam like plastic surgery and neurological surgery do. And ultimately, we decided that we really wanted to move in the direction as orthopedic surgery does, is only having cases from practice. Now, if we look at Miller's Pyramid, this might be familiar to some in the room. Miller's Pyramid is a framework for assessment of clinical competence. And the knows how are assessments of cognitive knowledge. Examples of those are multiple choice question tests like our written exam, or applied knowledge tests like our old oral exam was. But then towards the top are the shows how and the does. The shows how are OSCEs, the objective structured clinical exams, and then the does is what the individual is doing in real world practice. And we wanted to move from where we were to up as high as we can get on the top of Miller's pyramid to what evaluating and assessing what the candidate's actually doing in practice. So the written exam is going to remain the foundational knowledge assessment. Just because something's at the bottom of the Miller's pyramid, it doesn't mean it's any less important than what's at the top. You can't be at the top without demonstrating the broad and deep knowledge base of our entire specialty. So the timing of that exam, as I mentioned, is going to be unchanged, and that will remain the foundational knowledge assessment as part of initial certification. The oral exam is going to be an assessment of the skills, as I mentioned, required to safely, effectively, and ethically practice the specialty. The content is only going to include cases from practice. There's not going to be those structured unknowns anymore. Once again, we're not the objective of the exam is not to test the knowledge. It's to test performance in practice. Now, one of the areas that we decided to do differently than those other three boards is that we're including both surgical and non-surgical cases on the case logs. So the candidates are required to put in all cases they do over a 9-month period of time in the case log, but they're also required to put in with the policies described in our case log guidelines, 40 patients that they saw during those 9 months as new patients or consults that they did not operate on. And we choose, from the 10 cases we choose for the exam are a mixture of those operative and non-operative cases. There's just too much of the practice of our specialty that's non-operative to ignore it on a certification exam. And the candidates are able to initiate the application as early as the first year of autonomous practice. Autonomous practice is not being in a non-ACGME accredited fellowship. The candidates need to have completed the entirety of training before submitting an application for the exam. The only cases that are able to be put in the case log are cases that you independently and autonomously took care of outside of the training environment. We've had lots of questions from people that, I'm in a non-ACGME fellowship, could I still apply? The answer is no. We've had questions of, I'm a fellow, but I have like a 2-day-a-week general otolaryngology practice, or, within my fellowship. The answer is no. You have to be out of all training before applying for the exam. So in terms of the structurally, once the individual meets eligibility requirements, which are on our website, the individual submits an application. Once the application is approved, that applicant goes into a specific cohort. We label the cohorts based on the year of the exam that individual will be taking. And everybody has the same 9-month case collection period. It starts January 15th and ends October 15th. The reason why we start in January is that we do not want individuals, the first day they're in independent practice, out of fellowship or residency, feeling that they need to put their patients that they're seeing day one into a case log for their oral exam. We want individuals to be settled in their practices for 4 to 6 months before starting to submit cases for their boards. Now, during the process, we also do a 360 peer review on every candidate. For those of you in the room, you may have received these peer review surveys over the last few months from the board. Please fill these out if you know the individual. When you get the query, it's yes, I know them, and I could fill it out. And it's a quick thing you could do on your cell phone in a few minutes. If you don't know the person, you just click no, I don't know them, and you'll get a thank you screen, and you won't be bothered anymore. So, but thank you so much. We do 360 peer reviews on every candidate. And the board of directors looks at all the case for each individual candidate. We look at their case log, and we look at their peer review. And that's the credentialing process of every individual candidate for the exam. And for the candidates that are approved to move forward, they're told which 10 cases were selected from their case log. for their exam. So the candidates, they're not going to be tested on any case from their case log. They know the exact 10 cases that they're going to be examined on. The candidates are required to submit all the case materials as instructed by the board, and then they sit for the exam. In terms of the exam, it's, as I mentioned, it's 10 cases, a mix of operative and non-operative cases that are known to the candidates in advance. There are 2 sessions. Each session has 5 cases. Each session is 50 minutes long, so on average 10 minutes per case. And each of the rooms has 2 or 3 examiners, so 4 to 6 examiners will examine each candidate. There is only an in-person option for this exam. We do not offer, currently we do not offer this as a virtual exam. The individuals have to be in person at the American Board of Obstetrics and Gynecology, the ABOG National Center in Dallas, Texas. During COVID, the ABOG, keep in mind, they administer about 2,000 oral exams a year. So they built their own center to essentially have their administrative offices and conduct oral exams. It's an amazing facility. I don't know how they got this done during COVID, but they did, and it's a fantastic place to. And you know, I can tell you, the first time I did my site visit there, the comment I made is this place exudes professionalism. It really, it's a type of center that our exam is deserving of. The exam was in September of 25. It'll be in September of 26. After the September 26 exam, we'll be moving to an annual administration in March. So there'll be no exam in 27, but there'll be an exam in March 28, March 29, March 30, et cetera. Now, if we compare the scoring rubrics with the old exam, it was an applied knowledge test. We had 3 scoring domains: data gathering, interpretation, diagnosis, and management. With this new, and that's just really, from a structural standpoint, that's about all you could evaluate and assess on structured standardized protocols. But now we've got, this is a performance and practice evaluation, and we're able to evaluate a lot more on the candidates. And for every case, they're scored in 7 different domains. And you can see evaluation, diagnosis, management, complications and outcomes, ethics and professionalism, safety, applied knowledge, and case prep, organization, and clarity, which goes to communication skills. So we're able to evaluate and assess far more now in the candidates than what we were able to in the past. And there's still a 4-point rating scale for each of these score areas on the scoring domains. Now, each of these scoring domains, like evaluation, diagnosis, management, et cetera, for the examiners are anchored on these descriptions. And these descriptions, I'm not going to read through all of them. This is on our website. You could log in to the oral exam information on our website. This exact slide is there. We want to be fully transparent with the candidates about how they're being evaluated and assessed. So for an example, evaluation diagnosis, the description is arrives at an appropriate diagnosis using proficient clinical skills, sound reasoning, and effective resource utilization. So that's the anchor point for the examiners in terms of how they're rating the candidate for evaluation diagnosis for each of the 10 cases. So this year we had, usually we're going to have 330 to 350 candidates. This year was the transition year. We had 140 candidates, primarily because the only candidates who were eligible to apply were those that finished in 2023, passed the written exam, and didn't do a fellowship. And about 60% of the residents now are doing fellowships. So there were 140 candidates who sat for the 2025 oral exam. These were primarily general otolaryngologists in private practice for the most part. We had 103 examiners. We did have 12 exam coaches, and those were primarily directors. In terms of on our post-examiner survey, you can see 96% of the examiners were extremely satisfied with the ABOG Center. So it was thought to be a very good place for us to continue administering the exam. One of the questions we had, and many others did also, was 10 minutes per case enough? And that's what typically the other boards use in terms of that anchor point. So that's why we did also. And actually, of the examiners on the examiner survey, 94% agreed that 10 minutes per case was appropriate. Importantly, I'm going to show you some results data. The passing standard was established by the board before we administered the exam. This is best practice for certifying bodies, whether you're medical or non-medical, that you're not setting the passing standard based on trying to titrate how much should pass or fail the exam. You should set the passing standard in advance of administering the test, define what that cut score should be, and the methodology of establishing that cut score, and then the candidates need to meet the standard in order to pass. So the passing standard was determined in advance of the exam. This is a photo of the examiners at the ABOG National Center. The examiners, particularly for this first administration, put a tremendous amount of time and effort in being an examiner, and we're very grateful and thankful to our oral examiners who did really a fantastic job with the administration. For those of you who are interested in who those examiners are, you can go to our website, and on the banner you could see that there's a thank you to our examiners, and you can click the link and see a listing of all the oral examiners this year. Now, as I mentioned, there were 103 that did the oral exam, and on our post-examination survey for examiners, we had a 99, almost 100% response rate on that survey. Where have you ever seen 100% response, near 100% response rate on a survey before? So the primary question, did the selected cases adequately reflect the competencies required for board certification assessment? 95% said yes. Now I looked at, if you said no, you had to put the reasons why. And the people who said no, the few people who did, said, well, I only knew 5 of the cases of the candidates, not all 10. Some people said, I didn't think a tonsillectomy was appropriate because they're 2 easy cases. But like from the board standpoint, a tonsillectomy, septoplasty, adenoidectomy, tubes, these are all great cases. Like these are all really important cases to include on the exam. Feedback from the examiners blew it out of the park also. You could see this is just a sampling of feedback from the examiners that we received in quotes. Truly tested the top of the pyramid all the way down to the bottom. This is a better assessment if the candidate is qualified for board certification. This is truly an exam that best serves the public's best interest, et cetera. We did fantastically there. Now, in terms of the results, there were, as I mentioned, 140 candidates. There were 85%, or 119 of the candidates, met or exceeded the standards for board certification and are now board certified. There were 21 candidates, or 15%, that did not meet the standards and are not board certified. And you could see the board is moving away from saying you passed or you failed. Now that's still very applicable on all of our other assessments, particularly the written exam. But on this exam, the outcome really is you're certified or you're not certified. And so what we've described to those individuals who unfortunately did not pass the exam or did not meet the standards, I should say, is that at this time you did not meet the standards for certification. And those individuals could certainly reapply for a future oral exam. The psychometric parameters were fantastic. The internal consistency reliability was 98% or 0.98. The classification consistency was 0.99 for the exam. So I asked our psychometrician, how do I describe to a group of doctors what classification consistency is? And what our psychometrician described to me was that if the same candidate with the same cases was examined by 6 different examiners, they'd come up with the same, there's a 99% chance they'd arrive at the same conclusion in terms of certified or not certified. So you can't get much better than that. Now, if we look at the individuals who struggled on the exam, those individuals typically struggled in not one domain on the exam blueprint, on the scoring domains, but struggled on many areas. You could see of those that were not certified, over 80% struggled in the complications and outcomes area. Greater than 50% struggled in evaluation, diagnosis, management, safety, applied knowledge, and case prep, and just under 50% struggled in ethics and professionalism. Now, it's really important for me to describe complications and outcomes. We recognize every candidate had at least one or more cases on their exam that had a complication or a bad outcome. And that's part of taking care of patients, that you're going to have complications and bad outcomes. And the board certainly recognizes that. And we're not dinging candidates for having complications and bad outcomes. But what the board expects is that the individual is able to describe how they effectively managed that complication, or understand why they got that bad outcome and what they've learned and what they're doing differently in their practice as a result to have better outcomes in the future. And the inability to have that self-reflection on those bad outcomes or complications is what really drives the candidates to doing poorly in that area. So as I mentioned, for those that were not certified by the exam, they could either apply for the 26th exam this next year in September, or the exam after, which is March 2028. The advantage of applying for the March exam is that the case log will be prospective cases starting in January, that they can make changes to their practice and hand in a different and hopefully better case log of better cases for their exam. For those that want to go into the 26th exam, it's a retrospective case log of January to October of what they've done this past year. And so they really can't change anything they've already done for those cases that they'd retrospectively be putting in their case log. And this, from the board's perspective, we don't know what's better. So we're really leaving it up to the candidates at this time to decide what they want to do. The great majority of the candidates that did not get certified did decide to go into the 26th cohort. So for those that are interested in more information, you can go to the website, scroll to the bottom of your physician portal, click on oral exam, and there's a ton of materials there to review. I have a few minutes left. I'd like to just finish here on the forensic psychometric analysis. In terms of what is this, and this is something I didn't know what it was until a few years ago. And this is basically using statistical methodologies to detect cheating on exams. And some of the boards started doing this about 10 years ago. And I started learning from those other boards about some of the disconcerting findings that they were having related to doing these analyses regularly on their written exams. So the board, we decided initially to do this in 22 and see what happened. And then based on the results of 22, we decided to do it indefinitely moving forward. And so you can see we've performed these analyses on all our written exams from 22 until recently in 25. We've had no actionable findings on the written exam or the CPO exam. These are exams that are administered at secure Pearson VUE testing centers. The exams that we don't administer at secure testing centers, but at residency programs, are the in-training exam. And we have unfortunately had positive findings, or I should say they haven't been positive, but we've had findings on the in-training exam for all 4 years we've done it so far. And we, from the board staff standpoint, we thought we in the working with the residency program directors, and trying to get the word out through Sue Opto, we thought we did enough communication that we'd have 0 this year. And we all decided in the office we were going to have an office party if we had 0 this year. And unfortunately, we couldn't have an office party this year. So very fortunately, there's been no findings from the psychometric company we work with. That's really the best in class internationally at doing this work. We've had no evidence of widespread security breaches on our exam, which is great. But we've identified 14 copier pairs over those 4 years. So let me describe to you what Cavion is the name of the company, what they do. So we send them all the data, and all we do is we send them answer strings. So if you took the exam, we send Cavion your answer string. So we send them about 1,900 answer strings of the questions you answered. And what they do is they take each answer string and compare it. So if there are 1,900, they compare each one to the other 1,899 answer strings. And they look to see if there are two or more answer strings that have remarkable similarity to each other, too much that independent test taking likely did not occur. And they flag it if statistically the chance of independent test taking is less than 1 in 31 million. And then even that, it's not a guarantee. They do further, deeper analysis on those. And then they report to us the concerning, if there are any concerning findings. They don't know the program, the residency programs. They don't know they're at the same place. They don't know the seating charts. At that point, we look at the candidate IDs, because they don't get names, they get IDs. We look at the two candidate IDs. Oh, they were at the same testing center. Well, then we pull the seating charts. Oh, well, one is sitting here and the other is sitting behind and to the left or behind and to the right. It's like uncanny. It's like I don't know how they do the work, but they do it and do it awfully well. So here you can see the findings from 22 to 25. There were 2 in 22, 4 in 23, 3 in 24, and now most recently 4 in 25. And obviously I have this anonymized. I don't want to have the program names up here. These are all individual residency programs. And you can see the types of data over here. The probability of observed matching responses if independent test taking was occurring. I mean, I've never heard of these terms before. Undecillion. So in 25, you can see 25-2 and -3 are less than 1 in less than 1 in 125 octillion, or less than 1 in 55 septillion. So I went to Google, and I got this off of Google, of the definition of large numbers. And a septillion is 10 to the 24th power, and an octillion is 10 to the 27th power. Two of them up there were undecillions, and that's 10 to the 36th power, which is basically like almost copying every question off the other individual. And and Cavion told me actually the limits of their statistics go up to 10 to the 36th power. So you can't go higher than that. So anyway, my point is that as residents, please, I believe this is already communicated to you that the board's doing these psychometric analyses. I just want to emphasize to you how important it is not to be professional during the exam and all the ethics involved. From the board's perspective, these are like major breaches of professionalism and ethics to cheat on an in-service exam that purely has a formative intent. There's no summative intent. It doesn't affect your board eligibility or your performance on the exam. It's purely so you can evaluate your knowledge strengths and knowledge weaknesses and hopefully design individualized learning plans with your faculty to improve your knowledge base for the next time you take the exam. And if you go through it 4 times, during residency, hopefully you've acquired enough knowledge to do really well on the written exam. That's the whole point. It's formative intent. So to cheat on an exam, to cheat on any exams, but particularly it doesn't make any sense on this to put your position with your residency at jeopardy. In terms of becoming a volunteer for the board, there's lots of opportunities. I talked before about task force and examiners, experienced examiners, exam council members, directors. We typically do have a progression. Most people do start as task force members or new examiners, and then some will move on to get elected as an exam council member, as I know Nick has, and then to a director. And for those that are interested in board service for task force, we do take self-nominations. I will say, though, if you self-nominate for task force, it would be best to also at least ask somebody to also additionally nominate you. But the people that self-nominate for task force, from the board's perspective, those are individuals who are highly motivated to do an exceptional job, and we take a lot of those individuals who self-nominate for task force. If you're interested in being an oral examiner, you do need to be nominated by somebody who was elected to the exam council, a current or prior director. And if you're interested in who those individuals are, once again, you can go to the website and see. And I'm sure the 66, exam council members and our 18 directors, is probably somebody there that you know that you could ask to nominate you. If you've been an examiner and like to serve on the exam council, if you want to be nominated for exam council, you do need to be nominated by a current or former director. Once again, go to the website and see who those individuals are. The last thing I'll say about the nominations process is that, so for myself, I applied 4 years. It was my 5th year of applying to get on task force. For task force last year, for 30 spots, we had 232 nominees. So it is incredibly, even to get in as an item writer, even with having more than 90 item writers now, it's a competitive process. So if you apply, if you self-nominate and you don't get on, what I'd say is don't be dejected. It's not personal. It's just a numbers thing, and perseverance and persistence will and just reapply the next year. So, once nominations opens up in April, you just for all board certified otolaryngologists, there'll be a tile to submit nomination, and it's a very easy form to fill out online. And once again, it's really a honor and a privilege to be here today. Really greatly appreciative of this opportunity to talk to the department, and I'm glad to answer any questions. Yeah.
Hey, Brian. Thank you so much for the presentation. It's always informative hearing from you about the process, and I think for the residents, it's good to understand what they're getting, what they should expect going forward for both the certifying exam as well as the in-service. We're going to be later, and I'll have some more questions for you. But I think one of the things that when you brought up the in-service exam as being formative, I know of several fellowship programs that do ask for in-service exam scores. What's the board's, stance on this? I mean, should they be allowed to use these if we're considering these just formative exams?
Yeah, it's a great question, and I don't know why they're asking, but certainly, I don't think the board would have a position on whether they can use them or not. It's really up to those individual fellowship program directors and fellowships. I think I will say that over the years I've had some fellowship program directors for various different fellowships reach out to me and ask me, because they had a fellow who did pass the written exam, and they asked me, is there anything they could have used in advance to know if somebody was at risk of not passing, and really thinking more in the manner of giving the fellows more time to prepare. And there's some data in the literature. In all honesty, I don't know if it's still applicable because it was based on data from a long time ago. But Leanna Puskis published data. She did a research project with my predecessor, Bob Miller, that was published in Otolaryngoscope that suggested that for residents that did a third stay 9 or below, that performed at a third stay 9 rank or below for their PGY level, not for everybody, but their group level, at any point during residency, they were at a little higher risk of not passing on the first attempt. And then if you got third stay 9 or below twice during residency, and one of those times was as a junior, once it was as a senior, then it was significant worse. I mean, it was like a 12-fold higher risk of not passing on the first attempt. I'm not saying not passing at all, but not passing on the first attempt. And so I don't know if that data if those data are still relevant. I will say that I speak to many of the candidates who don't pass Paula to review their score report with me and to try to get some advice on how to prepare the following year. And to prepare for those meetings, I always ask my staff to pull their in-service scores for me because it's helpful for me to know, is it just a one-time thing they didn't do well in the written exam, or did they have problems with knowledge acquisition throughout residency in general? And not everybody, but the great majority that did not pass the written first attempt did not do well in the in-service during residency. So I think that third stay 9 or below, if you're there, that's concerning. And I suspect, I don't know why the fellowship program directors are asking for it, but I think that's the take-home point. Like I give to the residents is that if you're scoring consistently above third stay 9, you're probably on good track. But if you're not, then then you need to do something different than you're already doing to try to acquire the knowledge that you need to pass the written exam. Is that helpful?
Yeah, I've relayed that information to the residents before about the third stay 9. Pretty much every semi-annual meeting I'm talking about that. But no, I've worried that we've told people, okay, this is a formative exam, but nobody's using these grades, but then somebody's using the grades, right?
Yeah, and I don't think the board's going to comment on whether they should or they shouldn't. I think that the communication from the board is consistent that it's the intent of the exam is formative, and yeah, it's not. The intention is not for it to be a summative exam or summative process. Yeah. Hi.
Like I'm one of the chief residents. Do you anticipate the OTE being less predictive this year for success on the written exam, given the changing content distribution for the written? It's not reflected in the OTE, or hard to say. Any advice for how to use the OTE as kind of like a benchmark?
It's really hard to say, and the reason why I'm even saying that, even with those data that were published by Leanna Puskis and Bob Miller, that was we had already redone standard setting on our written exam, so it's really hard to tell, even if the last few years has been.
Okay.
So, but in terms of the level of changes to the exam blueprints, I think you'd have to redo the data analysis. You'd have to redo it. Yeah. One of the things our psychometrician is working on that might be really helpful is that, and I don't know if it's going to be possible or not, is creating a predictive tool for, like, as a resident, you'd be able to put in your group stay 9, and it would give you a predictive value of the prediction of passing the written based on how you did. But we're trying to work through a lot of the statistical details of that now.
Sorry. Thank you for the talk, Dr. Nussenbaum. I was wondering if you could go into how the cases are selected for the exam, and is there any criteria for that?
Yeah. So for the oral exam, all the cases are selected by directors, and but as you could imagine, so even for this year, it's not 330. Like next year this year it'll be 333. Last year was 140. For each individual, we need to look through their case log that has hundreds of cases and pick 10. So the case log has enough data in it to give us enough information for a computer to initially make those decisions for us. So we worked through an algorithm with our technology partner over a period of several months that initially the computer does a pass through the case log and will pick 12 to 15 cases that are felt to be representative of that individual's practice. and then the directors look at those cases, and then they look at the entire case log, and then they have to whittle that down to 10, but then they'll substitute in and out some cases here and there to wind up with those 10. But we want to make sure that the 10 cases that are selected are representative and reflective of that individual's practice. But also we want to make sure that there's like basic bread and butter otolaryngology stuff in there. So if you did a adult tonsillectomy, if you did primarily adult, I say adult, if you did a tonsillectomy, there is a good chance that one of those cases will be on the test. If you did a septoplasty, if you did a set of tubes, like those are examples of some of the cases that some of our examiners felt were too easy. But from the board standpoint, we want to be testing on basic bread and butter stuff, a thyroidectomy, a parotidectomy. So you could almost, as a candidate, predict, what cases are going to be there. And if you had a difficult, complex case, there's a good chance that'll be on it also. But that, once again, it's not to ding you, it's to evaluate and assess how you handle complex patients and complex patient care.
Thanks, Brian. That was great, as usual. And here's Brian's contact information. I'm sure a lot of people have questions. So thanks for.